Heart failure. The heart is a double pump. The right side will pump deoxygenated blood to the lungs for oxygenation, and the left side will pump oxygen-rich blood into systemic circulation. This process will provide a continuous supply of oxygen and nutrients, cellular metabolism, and mechanism to eliminate carbon dioxide. Disturbances in one part of the heart, if it's severe or prolonged, eventually affect the entire circulatory system. Heart failure is defined as the inability of the heart to pump sufficient blood to meet the body's metabolic needs. The ejection fraction is an estimate of the heart's efficiency or percentage of blood that the left ventricle will eject when it contracts. It normally will eject 55% or more of the blood that fills the left ventricle during diastole. With congestive heart failure, we have an accumulation of blood and fluid in the organs and the tissues due to impaired circulation. We can have acute heart failure where we see a sudden change in the heart's ability to contract, and this can cause life-threatening symptoms and pulmonary edema. With chronic heart failure, the heart's ability to pump effectively is gradually compromised. We see impaired contractility remaining prolonged. We have 4 different classes of chronic heart failure, and it basically is going to affect the client's ability to perform physical activity. With left-sided heart failure, it's going to result from various conditions that impair the left ventricle's ability to eject blood into the aorta. And causes of left-sided heart failure can include myocardial infarction, cardiomyopathy, which is an enlarged heart, and hypertension. With right-sided heart failure, this results from the right ventricle failing to eject blood into the pulmonary artery, and then it's going to cause congestion of blood in the venous vascular system. Causes could include left-sided heart failure, chronic obstructive pulmonary disease, or COPD. Basically, it's caused by an inability of the heart muscle to contract because of direct damage to the muscular wall. There are some compensatory mechanisms, though. If changes in the heart function occur over time, the body will use those compensatory mechanisms to temporarily improve cardiac output. So we may see an increased heart rate, or the blood pressure increases as the heart works harder to push that blood out to those tissues and improve cardiac output. With reduced cardiac output, the client is going to be hypotensive, or that low blood pressure, and that will stimulate the sympathetic nervous system to release catecholamines. And if you remember, that's going to be your epinephrine and norepinephrine to help raise the heart rate and blood pressure. This will then increase the force and contraction of the heart to maintain the blood pressure, but it also increases myocardial oxygen demand, so the heart is going to require more oxygen. Epinephrine will then cause the blood vessels to constrict. The body will shunt more blood to the vital organs. In other words, it pulls blood away from the non-vital areas such as the legs and the arms and the bladder and the kidneys, and it will send it to the heart and the lungs and the brain. The ventricles are going to then secrete a neurohormone, B-type natriuretic peptide, also known as BNP. Now, this is an important lab to remember. BNP is going to be very indicative of heart failure. The higher the number, the worse the heart failure. We're going to treat it to try to reduce the heart's workload and improve cardiac output. So we can do this through dietary modifications. We need to decrease sodium because, if you remember, water follows sodium. And if we have a lot of sodium in the diet, we're going to hang on to more fluid. And if we're fluid volume overloaded because of the congestive heart failure, we don't need any more fluid. We'll put the client on fluid restriction. We'll encourage lifestyle changes that include exercise, weight loss, and decreased cholesterol levels. We can do drug therapy, digitalization with digitalis. We can, with acute heart failure or pulmonary edema, use the inotropic agents such as dopamine or dobutamine. We can give diuretic therapy, such as furosemide. It's one of the most common, and it is a potassium wasting medication. So one of our loop diuretics. We can give vasodilators, ACE inhibitors, such as captopril or ramipril. We can do cardiac resynchronization therapy, which restores synchrony in the contractions of the right and left ventricles. And this is used primarily for clients whose heart failure is caused by dilated cardiomyopathy. We can do an intra-aortic balloon pump, which is temporary, secondary mechanical circulatory pump that supplements the ineffectual contraction of the left ventricle. We can do surgical treatment, which would be our ventricular assist device, our cardiomyoplasty, our surgical ventricular restoration, a total artificial heart. With nursing, it's very important for us to teach about the medications, lifestyle changes, and potential diet restrictions. In the hospital setting, when we're administering medications, we always monitor for therapeutic and adverse effects. We also need to monitor for signs of excess fluid volume and evidence of electrolyte imbalances. We should also promote oxygenation and balance activity with rest and provide support to those family members. And this is what our cardiac output looks like as far as the formula. With treating congestive heart failure, unload fast. With left-sided heart failure, we are looking at the left ventricular failing, and that muscle is not contracting forcefully enough to expel blood into the systemic circulation. So then we start seeing backup. So think about the blood flow through the heart. Where does the blood come from into the left ventricle? Well, we know that this is coming from the right or left atria, and the blood from there comes from the lungs. So if the left ventricle is failing, then it's going to cause a backup. So think of a clogged sink. You have the clog and everything backs up past where that clog is. So the left ventricular failure is our clog. Everything's going to back up to the lungs. So we're looking at complications in the lungs, in the pulmonary vascular bed, where fluid accumulates and begins to create congestion. We'll have impaired gas exchange, and those cells are going to become very hypoxic, and we have an accumulation of carbon dioxide. The client will also experience hypertension, tachydysrhythmias, valvular disease, cardiomyopathy, and renal failure along with that heart failure. So we're looking at potential causes of the left-sided heart failure. We talk about the afterload, which is the force that the ventricle has to overcome to be able to empty itself. And it increases with atrial or arterial hypertension, aortic stenosis, pulmonary hypertension, or excessive blood volume from renal failure. We also see a reduced ventricular ejection volume and loss of elasticity in the muscle because of cardiomyopathy. And when we're talking cardiomyopathy, we're just basically, again, talking about an enlarged heart. It gets to a certain point and it loses its elasticity. It's not going to stretch anymore. These clients, again, are going to experience hypoxemia, unusual fatigue with activity, exertional dyspnea, which is going to be the first symptom that we see with left-sided heart failure. Orthopnea, again, this is where they cannot rest when they're laying flat. They have to have their head elevated. They have paroxysmal nocturnal dyspnea, and that requires them to sleep with several pillows in the bed, or they have to sleep in a chair. Their heart rate is rapid, might be irregular, blood pressure is elevated, they may have a cough or hemoptysis, coughing up blood, moist crackles, and they're going to have a decreased urine output because they're holding on to fluid. We diagnose with chest x-rays, with an echocardiogram, a multiple gated acquisition scan, arterial blood gases, or pulmonary artery catheter. With right-sided heart failure, the right ventricle is not forcefully contracting and pushing the blood into the pulmonary artery. So we begin to see complications with congestion of blood and backflow, excuse me, that will accumulate first in that right ventricle, then to the right atrium, then we go backwards to the body. So again, think of that clogged sink. The clog is the right ventricle. Where is that blood coming from? Well, the right atria, which gets blood from the body. We're going to see chronic respiratory disorders that potentially develop because of right-sided heart failure, such as cor pulmonale, which is right-sided heart failure that is that affects the lung itself and causes lung damage. So with right-sided heart failure, this client, again, all of that fluid is going back to the body. They're going to start having unexplained weight gain. They're going to have that edema in the lower legs, especially. They may develop ascites, an enlarged liver or hepatomegaly, and jugular vein distension. The organs in the abdomen can start becoming enlarged, and that creates dyspnea. They start developing that fluid retention, so their rings, their shoes, their clothing becomes tight because of edema. And they can have accumulation of blood in the abdominal organs that causes anorexia, nausea, and flatulence. Again, we can diagnose with chest x-ray, the ECG, echocardiography, a lung scan, and pulmonary arteriography, and looking at those liver enzymes. So once again, left-sided heart failure mostly affects the lungs. Right-sided heart failure mostly affects the body. An elderly client has had a myocardial infarction at the right side of the heart. Which of the following signs should the nurse anticipate when assessing for heart failure? Nausea, heart murmur, crackles in the lungs, edema in the feet and legs. This will be edema in the feet and legs. Which of the following client teaching points should be included in the discharge planning of a client who has heart failure? Select all that apply. Weigh yourself daily. Take your blood pressure before taking digoxin. Increase your carbohydrate intake. Take your diuretic early in the morning. The client should weigh themselves daily and take their diuretic early in the morning. When administering diuretics, we normally are going to administer these prior to 2 o'clock in the afternoon. The earlier the better, because we don't want to affect the client's rest time at night by administering the diuretic at a later time. A client may be at risk for impaired gas exchange related to pulmonary congestion, secondary to left ventricular dysfunction. A nursing intervention to assist the client with maintaining adequate gas exchange includes all of the following except maintaining the client in a high Fowler's position, administering supplemental oxygen, limiting physical activity, excuse me, or providing foods and beverages that are a good source of potassium. Providing those foods and beverages that are a good source of potassium. With cardiogenic pulmonary edema, again, the left ventricle is incapable of maintaining that sufficient blood output, and now the lungs are filling with fluid. These clients are experiencing sudden dyspnea, wheezing, orthopnea, restlessness, a cough, and this cough may be productive of a pink, frothy sputum. They may also have cyanosis because, again, our gas exchange is impaired because of that accumulating fluid. Tachycardia, severe apprehension, respirations that have a moist or gurgling sound, hypotension, and peripheral pulses might disappear. We diagnose with chest x-ray, pulmonary infiltration, ABGs. We're going to treat it with supplemental oxygen or even mechanical ventilation. Drug therapy such as our dopamine or dibutramine, digitalis, diuretics, nitrates, ACE inhibitors, and our calcium channel blockers, along with morphine. Morphine is a really interesting medication when we're talking about respiratory issues. It's going to do a multitude of things. It's going to decrease myocardial oxygen demand, so the heart does not require as much oxygen. We know it's an analgesic, so it's also going to do that, but it's also going to decrease anxiety, and this is going to help with the client's respiratory status. It also has a mild bronchodilator effect, so it's going to help open those airways. We can also use the pacemakers the LVAD, the cardiomyoplasty, or artificial heart. As far as nurses, we need to get that IV in place if it's not already established, because we're going to be giving a lot of medications through the vein. We're going to do a continuous monitoring of the heart, pulse oximetry, automatic blood pressure and heart rate measurements. We're also going to place a urinary catheter to help measure output, oxygenation, and we'll do frequent mouth care. And your post-test.